A man recently came under my care who has unfortunately suffered severe catastrophic renal disease, kidney disease, and I would like to use this case, as it's unfortunately so common, the pathophysiology as it transcends that I see every day with men that are on steroids. It's a multifactorial piece, as most things are in internal medicine. It's never just one thing. It's going to be multiple factors coming together. And for this video and for this case, I saw again some more pieces that I could put together in this linear, if you will, approach to looking at all the pieces, how a man's kidneys will go under failure chronically and slowly and acutely at the end and end up suffering. I saw that. I've put a few more pieces together here that I've seen, and I want to educate. My objective here is for strict education and awareness of men that are using steroids to be very careful yourself and to understand these mechanisms so this doesn't happen to you. And if you're a very young man, and teenagers or young men in their 20s, the organs are always healthy, and then it's the course of time in which there is a demise, and there are so many pieces to it. If you could obviously understand and be monitored during this period on yourself and understand this with your healthcare providers, it will protect you and you'll do better. In the end, living longer and just being older, I could tell you, has its own complications. Just living longer is a complication, but you want to have the best quality of life. So with that, and I do thank you guys for trusting me and loving me and all the support for years. I try to read all the comments. I can't tell you from the 10 years of doing this how happy in my heart and how enriched I am. So thank you so much. Let's go. Here we go, guys. Back to the whiteboard. It's been a long time. Renal disease secondary to anabolic androgenic steroid use. This is a 42-year-old man that has been using steroids, anabolic androgenic steroids, for 20 years, sundry drugs. That means many steroids. Always living on testosterone, about 750 a week. He came into the hospital, and we'll talk about that. He was up to 320 pounds, 5'10". This is part of the risk. This is just a monster. This man genetically, like the pro bodybuilders, they have such great genetics. They're just born with myocytes and just born with incredible great muscles, and then they put it on steroids. Please, guys, follow me with this. So this is one of these men, great genetic. This guy is just super muscular genetically, and that's why he loved it, and that's why you love it, and that's why I have loved it. I've loved to be muscular. I get it, but I'm also terrified of disease and suffering. So pay attention, guys. He starts off with 20 years, he's 42, 20 years of the steroid use. What I see and how I could see this, I've seen it before, the implications in the history, some common threads that I've seen so often. In 2013, remember, this is a presentation recently, this is August 2021. 2013, so years ago, 2013, he ends up in the hospital with acute rhabdomyolysis. Hey guys, quick pause. As you noticed over the last month or so, I've been doing a lot of traveling. I want to mention a tool you may want to use if you're a traveler like me. Surfshark VPN. Surfshark is jam-packed with features that benefit travelers. It allows its users to overcome location-based price discrimination on things like car rentals by connecting to VPN servers in other countries. Surfshark will also help you not get frozen out of your own bank account when you're traveling far from home. Lastly, and this is my favorite, Surfshark will allow you to safely connect to public Wi-Fi by encrypting your data. I relied on public Wi-Fi when I was on the road last month the whole time. Surfshark will allow you to stay safe on the road. Acute rhabdomyolysis. This is complicated. He ends up in acute renal failure then in the hospital that required dialysis. That's rhabdo that required dialysis to heal. I heard that when he told me these stories, and I read all the notes. I really read over. A cardiologist presented this patient and recommended this patient to me. That's how they came. A lot of these guys come to me from other doctors. So thank you, good doctors. So going back to 2013, he's in dialysis. He says for 2 weeks or something, so it worked, the dialysis, or maybe it was just short period in the hospital. He didn't really remember. So after the dialysis, years ago, we know this. He had chronic kidney disease. I don't know what his creatinine levels were. I kept asking, what's your baseline creatinine? Is it 1.5? It's very important, guys. 1.5? Is it 1.7? Is it 2? I see this stuff all over the board. He didn't know. He had hypertension for sure. He resumed steroids back to 750 a week, equipoise. He did trend. He's done all these drugs. This guy loves being muscular and just loves it. He's a great guy. He just loved to do this stuff. How much protein? A lot of protein. And then, of course, you always have these NSAIDs, the non-steroidal anti-inflammatory. Now, the problem with this first step that led to this current condition and his demise is that he didn't have any follow-up. I said, sir, when you were in the hospital, the kidney doctors, the nephrologists saw you. They told you to follow up, and they wanted you to follow up with your kidneys to monitor you. And he said to me, Doc, it's true, they did, and I did not. That was from 2013. So that's a big piece here. So guys, you need follow-up. You need to watch these numbers. You need to understand this process. And you got to keep your doctors on point. And go to a new doctor who's really an expert. And you got to put all this stuff together, guys. So he doesn't have follow-up. Then, recently, August of 2021, he has several weeks of severe dyspnea, shortness of breath, where it's amazing what people can tolerate, what some of these people, what men can tolerate. He was short of breath, and he was sleeping at night where he had dyspnea. He had classic dyspnea that we see in heart failure. And he had to prop himself up on pillows, and he even had to sit in very awkward positions just to breathe, and he would sleep, he'd get up, and he'd feel better. This went on for weeks until one morning, he woke up, he's walking around, he couldn't catch his breath, he was just so short of breath. He called work, I can't come in, he went to the ER. Here we go, guys. Here's the acute presentation in the ER. Hypertensive emergency. Blood pressure 210/150. Yeah, it's possible. I've even seen it higher. Not on steroid users. These are people that are older and things break, guys, and with chronic kidney disease and hypertension and heart disease. So that's big. That's high though, right? 210/150. Hypertensive emergency. He's diagnosed immediately in acute renal failure. He has ensuing non-ischemic cardiomyopathy. But let's get into this. So I'm giving these numbers to you guys because you have to understand it. This is a super amazing case to put all this stuff together, guys. It's complicated, so obviously you could research your stuff, but only a good internal medicine physician is going to understand this stuff. But I encourage you, become doctors, internal medicine doctors. BUN, I leave out the other electrolytes, you're fine. BUN 96, creatinine 12 on presentation. Hold off on the CBC for a minute. His cystatin C is 4.03. That's the secondary marker. Beyond having a lot of muscles and dehydration, people think that, and it's true that the creatinine can falsely represent what looks like kidney disease, chronic kidney or acute kidney disease, because you have a lot of muscle tissue. Boom, that's where the cystatin C comes into play. So look at this, the upper limit normal, I put these ranges in, forgive the bad handwriting, 0.5 to about 1.2, maybe 1.3 max, 1.3, he's 4.0. So that's a confirmation that his kidneys certainly are in trouble. His estimated GFR is 13, normal is greater than 60. Now, going on more, because when he presents, the hypertension is so great, he's short of breath, he's in heart failure. Okay, he's been in heart failure. The weeks and weeks of shortness of breath at night, laid back, that's classic heart failure. So they have to rule him out that he's not having an MI. ECG was normal. Okay, they looked at troponins, they looked at other variables. They made a decision that he didn't need to go to the cath lab right then. This is, guys, emergency room is badass. These guys are amazing. So they check, and these are, again, there's a lot going on, guys, but these are the salient focus pieces that I present to you guys, relevant for the case to understand. The BNP level, which is another marker for heart failure, is over 2,000. If it's over about 450, it's consistent clinically with heart failure, okay? So BNP heart failure, acute renal failure, cystatin C supports it. We have the BUN, the creatinine levels. What else we have? CK 627, anything over about 200 is abnormal. So many men that just train hard and just have muscle, they're going to be over 200, 300 or 400. Be very careful with making any kind of diagnosis on that. You have to understand the clinical condition. Now, rhabdomyolysis, as I'm here, I want to point out, that's when the CK is over 10,000. And again, people throw that word around, rhabdomyolysis, they so softly and or harshly. It's very complicated to make a clinical diagnosis of rhabdomyolysis. Again, I'm not saying you don't have it or you have it. You just be careful with that word. So many guys come in that were in rhabdo. Like, are you really in rhabdo? Because wait till you see how this case right here ending up for him, because he was in rhabdo. Years and years ago, 2013. That's the beginning, guys. Listen to this. That's such an important piece right there for how this thing, that was the beginning of this. Back to the CK. He's not in rhabdo right there. He's not in rhabdo. CK 627, that's not rhabdomyolysis. He's in acute renal failure. It's elevated because he's muscular and he is in renal failure. So very complicated. Now, his echocardiogram, transthoracic echocardiogram, ejection fraction on admission is 15%, guys. That's heart failure. With the grace of God, over the course of his stay, he was in there for, I think, 5 days. He was discharged. He was back to 40%. Still low. Hopefully getting better. He also had 6.7 grams of protein on a urinalysis. They did all this in the hospital. He had cardiology on board. He had renal guys, nephrology guys on board, and a good internal medicine doctor overseeing the whole thing. Hospitalist. So that's nephrotic range, right? So this is the details. This is right here in the nephrology. So, and what's also relevant to this case, we're going to discuss here in the end, the mechanisms of action that I'm here to give and to bring these pieces together for you guys that really no one else has ever kind of put this stuff together like me. If some guys have, that's awesome. Let's all work together. Complement factor C3 is down. In the end, we're going to talk about that. He has a diagnosis from the hospital when he's discharged home already of focal segmental glomerular sclerosis, FSGS. That is the one that the anabolic steroids, you could see all the research papers, that's the type of kidney demise secondary to steroids. But it's not just the steroids. So, what's the mechanism of action for this FSGS? The focal segmental glomerulosclerosis that I don't want to see. I see it in the early all the time. I see it early all the time with normal creatinines, proteinuria, and just a history of steroids with genes. Men have different genes, guys. You have different fingerprints. You have to believe me on this stuff. FSGS. What's the mechanism of action? I brought you through this man's presentation. Anabolic androgenic steroids, no kidding. Which ones, how long, who, what, where, we don't know. Definitely hypertension. You gotta check the blood pressure, guys. I'm begging you. And I love you young guys. It's amazing they're checking the blood pressure. And do you take tons of steroids and then tons of drugs to control the blood pressure and all? Who knows? And there's some criticisms on that, but that's you have to start somewhere with harm reduction. And obviously, of course, it's don't do the drugs, man. But that's just that simple? We know it's not. And we're not discriminating. We're not here to profile and discriminate on people. We don't do that. Anyone. So steroids, hypertension, that's right there. This man came in, look at this, 210/150. You know for this the years between 2013 and the presentation, you know he was hypertensive. I know he was hypertensive. The man, incredible man. Men just don't, it's a silent killer. It's a silent, they just don't know or check. Or maybe he was fine up until a month before. All the above, who knows? Probably not. Protein, steroid use with non-steroidal. That's the Motrin and the Aleve, guys. Not Tylenol. It's Motrin and Aleve. It's not aspirin either. Guys blast it. They take a lot of protein. They're big, just being huge and big. And maybe, we don't know, maybe it's the spilling of the myoglobin. The spilling of the myoglobin chronically into the circulation. Again, that's the rhabdo. Is it 627? Or if you have 300 or I see it all the time. We don't know. What is it? Just muscle? Is it bad? Is it renal toxic? Is it chronic? What is we don't know. Put it all together, guys. I'm trying to do it. Genes. Boom. The C3. I put it together. I saw it for the first time. I said, wow, this is, because they talk, these nephrology guys, great job. These guys are brilliant. They don't know about steroids. I'm bringing it together. But they don't know what Anadrol is and Depol, and they don't care. They don't do steroids. They know what steroids can mess things up, but then complement deficiency factor dysregulation. This is brand new. I was reading on this. This may be it. This may be the missing link of what happened to him and other men that end up going into early, mid, and late stages of FSGS. It may be that the complement dysregulation, it's like an autoimmune thing, guys. I'm not a rheumatologist. I'm not a nephrologist. I'm just an internist. But I can tell you, I understand that. That's another moon that lines up. It comes into position. So again, genes, and this maybe, they actually put it in the notes for the next nephrology team, if he gets a transplant, they said. Because if he gets a transplant, which he's going to probably need a transplant at some point. Thank God he's stable. He's making urine. His electrolytes are fine. He doesn't feel well. We're going to talk about the anemia and these things, and that's secondary to the renal disease. Very chronic. This is a lot of interplay here going on. A lot of internal medicine. But we don't know. So in the end, genes are a huge piece. Are you risking it, and what genes can you check? We're not there yet. So what's going to happen with the management? Let's go right into the management. Okay, he's got nephrology guys forever. He's got cardiology guys and an internal medicine guy, and he has me, testosteronologist. So, and I'm helping him put all this together because I love it. I just love this. So he's got chronic kidney disease, stage 5 right now. They're holding off on transplant or hemodialysis for right now because I said he's stable, he's making urine, electrolytes are stable, he's fine. That's those guys. I stay away from that. Interesting. He's anemic. I want to talk about the anemia. He on the CBC, which I see usually the opposite of this, right, guys? Polycythemic. So he's 11.1 and he's 32% of grams per deciliter. This hemoglobin hematocrit. Why? Why is that? Because he is obviously had chronic kidney disease, and chronic kidney disease, we know you have chronic kidney. Your kidneys make erythropoietin, and there's other stimulating factors. With these factors together, with the increase in the erythropoietin on androgens, it stimulates and works with the bone marrow to increase androgen-induced erythrocytosis that leads to polycythemia. He's anemic and he doesn't feel well. So these guys are going to work on that. This is an indicator that his kidneys are severely damaged and he's going to need a transplant. Right there. And I've talked to nephrology about this already. So, and then are there iron transfusions where they have to increase that. They have to look at parathyroid, vitamin D, regulation, guys. Very complicated. Kidney guys, I remember in residency, the kidney guys were thought to be kind of the smartest guys. You know, like cardiology guys and rheumatology and endocrinology guys aren't smart enough. We kind of always looked up to the nephrology guys. I've said it before. So, so he's got the nephrology guys forever for management. And guys, he's going to be on TRT. That's where I come into play. He's going to have massive anabolic steroid-induced hypogonadism. Of course, I'll be giving him TRT. And they know it. The doctors reached out and referred him to me for this, but we all put it together. The guy's not going to go back on steroids, and I hope he doesn't, but some men do. And then you're getting into this whole thing again, even after getting a renal transplant. But it is what it is, guys. Cardiology, his ejection fraction is low, and it came up from 15 to 40%. So he's on blood pressure medicines. He's on an ARB. He's on a calcium channel blocker. He's on incredible medicines. They have to look at his coronary arteries carefully, because if they do a CT angiogram with the kidneys the way they are, they're going to destroy the kidneys with the IV contrast dye. Guys, please, this is super complicated, but this is why I love this stuff. Thank God his heart is okay and getting better. So this really is strictly a kidney case, but the kidneys and the heart are intimate. I've told you guys, it's cardio-renal. It's cardio-renal syndrome. I wrote an article, I think in 2010 about this, back in Muscular Development. Thank you, Steve Blackman, Ron Harris. So, hypertension, what's the end point? Management, where you understand, guys, you see the mechanism. I brought you through the case. Here's the chemistry. Hypertension. His blood pressure's really, it's great now. It was actually too low. He was on Entresto. It's a very special medicine for in the hospital and outside the hospital too, for people with heart failure, and they tanked them. So you can go too low, that's not good either. So blood pressure, hypertension, body weight. That's an interesting piece, because if you look for the data on FSGS, just being very muscular, again, remember the rhabdo guys and the myoglobin, just being very muscular is one of the components, the mechanism of action of the demise. So they're going to want him small. It's hard for him. I'm already helping. I'm trying to help the guy to realize he has to shrink down. He's suffering because you know the guy, like me and like a lot of us, that we have the body dysmorphia. Come on, guys. This is super common. There's the spiritual side, the body dysmorphic side. So he has to shrink down. You can't take too much protein. You can't go back to the steroids and the protein. Never NSAIDs. That's going to be a death nail. NSAIDs. You guys, people don't know this. Pay attention. So again, no steroids. He'll be on TRT. We got to keep him down, his body weight down, and then he's going to get a transplant. We just don't know when. There it is, guys. Hope you liked it. Please understand it's a little chaotic, but I think it's pretty straightforward and clear, the stepwise progression of what happened to this man. I really hope this helps so many of you understand to be careful with steroids. Please, very, very careful. If you end up going on TRT, that may be an option, but you have to watch blood pressure, cholesterol, the sugar, all the stuff that I do as an internist, and you can get on the anabolicdocapp.com to have access to me and all my medical information. Thank you very much, guys.